Recording in progress.
Good evening once again. Our speaker is ready and poised for action. So, as we have advertised previously on our composite CPD schedule, and as we posted yesterday, we have a very distinguished personality amongst us who has been in the Ghana Health Service system for a long time and who understands how to treat patients and the reason why we treat patients the way we do, to take us on a category B CPD. As you realize, the category B CPDs are not many. So I encourage that if you know someone who is not yet on the bill, kindly call them to join, because the category B CPDs this year are not that many. So if you miss any of them, it can affect you. So please, let's encourage our colleagues who are not here. Alert someone to also alert another person to join us as we take this CPD. Very important. Understanding the patient charter of the Ghana Health Service. Invariably, this is the charter that any of us, even those of us who are in the private practice, will be judged by. Should we come under any scrutiny based on complaints by a patient or a client we are taking care of? This charter that is carved out of the Ghana Health, Ministry of Health charter, is very, very important and crucial for our practice. So, to take us on the very important topic, understanding the patient charter of the Ghana Health Service, we have our very own, the chief dietitian of the Ghana Health Service Diet Therapy Unit, Dr. Ruby Arthur. We affectionately call her Chief. She's been a chief for a long time. So Dr. Ruby Arthur is the chief dietitian and the head of the Diet Therapy Unit, Institutional Care Division, Ghana Health Service Headquarters. She holds a doctorate in theology from the Emmanuel Bible Institute and Seminary, Brooklyn, New York, USA, the Ghana campus. She holds an MSc, Master of Science degree in International Business, University of Ghana Business School. She is also a holder of postgraduate certificate in public health, leadership and health promotion from the Griffith University, Australia. She is a part of health workers team that went to, she was part of the health workers team that were sent to Dimona, Israel, for initiating the regenerative health and nutrition program in the Ministry of Health. She holds a postgraduate certificate in dietetics. BSc, Bachelor of Science degree in Home Science from the University of Ghana. And she is the dietetic team lead for review and dietary management of the nutritional needs of the Bansa conjoined twins at the Greater Accra Regional Hospital, July 2021 till date. Ladies and gentlemen, Dr. Rubiata is not only here alone, she's here with Mr. Albert Yaunu from the medical legal unit of the Ghana Health Service, who will be assisting her in her presentation. So, Dr. Rubiata and Mr. Yaunu, you are welcome.
Thank you very much.
I'll now hand over to Dr. Rubiata to take us through this all-important topic, understanding the patient charter of the Ghana Health Service. Over to you, madam.
Thank you. Please, can you hear me?
Yes, loud and clear.
Okay, thank you very much. Thank you so much, DRD. God bless you so much for your attention. Yes, so we are going to have a discussion on the patient charter of the Ghana Health Service. But to start with, usually the Ghana Health Service is an implementing agency. So what happens is that when there are policies or documents to be written, we initiate it and then we do it together with all the other agencies of the Ministry of Health, plus the teaching hospitals, the church institutions, faith-based and all that. So it's not only for Ghana Health Service, but for all health facilities, if I may say so. And then to continue, I'd like to put in a disclaimer. For the sake of the discussion, I may say certain things because this is the patient's rights, the patient's charter rights and responsibilities are very legal issue, if I may say so. When I was in a presentation, I realized I had to be calling the medical legal people to be asking them certain questions to get a clearer understanding. Although I thought I knew so much about it, but I realized that I really needed to talk to them. So if I say something which is out of order or out of place, or I make any joke or say anything, to just be in the context of what we are discussing for today. And I cannot be held or bound by it, please, in any legal way. I hope that's fair enough. Thank you very much.
That's exactly so.
Okay, so thank you so much. Okay, so the outline of the presentation is the outline, please. We are looking at the patients, their rights, and then their responsibilities. So what's the charter all about? It was launched in 2002, and the current version is 2012. And so, but then there are discussions underway for the review of the document since it's been over 10 years now. And it's also used by all health facilities, not only for Ghana Health Service, but by all. Anybody in Ghana who sees or anywhere, wherever patients are seen to, it's being used. And the basic aim is to improve the quality of service for the patient, for our clients, and ensure protection of the patient's rights as well, and importantly, to protect the rights of the patients. So basically, that's what we are supposed to do. Please, can we go on to the next slide, please? So what it embodies, the healthcare facilities are required to provide for and then respect the rights and responsibilities of our clients, whether they are families, the health workers ourselves, and other healthcare providers. So it means that then when you have a facility, either private or government owned or whatever it may be, you should make sure that there's provision of all the care that depend on the level of care. If you're a health center, it's spelled out clearly what facilities you can provide for your clients who are coming in. We know that usually when you go to CHIP centers, there are certain medication they can't even prescribe and certain treatments they can't do because of the NHIS reimbursement and also the level of specialists who are there. So you have to have a certain amount or a certain level of care, amount of care that you can provide for the patients. So at each level, you should make sure that that provision is made for by the patients. and also respect their rights. And all the rights are entailed in whatever we are going to discuss. So when we go and realize that all the 5 A's will be made mention of: accessibility, accountability, availability, and all the 5s. We'll make mention of all of them. And then also, healthcare facilities are expected to be sensitive to patients' sociocultural and religious backgrounds. Being very sensitive, it means that we have to also ask ourselves, if we were the patients, how would we feel like the way we are treating them? Would we think that it's okay to be treated in that manner? How we even talk to them? What kind of assistance that we offer to them? Whatever we do or whatever effort we make in providing care for them, would we also love to be treated in the same manner? So we have to be careful of what we do to our patients. We should look at their age. That's why in the health service, we have some people, when you're over 70, there are certain things that are waived so that you don't have to be paying for all services. And if you are poor, you're a pauper, obviously, you have certain also arrangements have to be made for, so you can have the level of care that is needed for you. So all that is taken into consideration. Gender, we have to also be gender sensitive. We talk so much about the girl child, about women, and then the aged, and now we are including men as well, the male gender, yes. They also should be sensitive to their needs as well. Some of them, they are males, but some of them could also be very vulnerable. And any other differences that is deemed necessary, that is deemed necessary. And we also have to look at the needs of the patients with disabilities. So the Ghana Health Service is doing so well when it comes to this. As we go on, we'll see what the Ghana Health Service is doing. And we also have the patients charter. Please, you can just go to the previous slide, yes. It also ensures that service personnel, as well as patients, clients, and their families, understand their rights and responsibilities. They should understand it, so that when they come to a facility, we are responsible for ensuring that they understand whatever treatment they are going to, and they understand their rights and responsibilities, so that when we are offering any treatment to them, we should explain to them. They should understand it, and what they can do or not do, what they can accept and not accept. Please go on. And what it embodies. Okay, so we've done what it addresses. We should have easily accessible, equitable, and comprehensive healthcare of the highest quality within the resources of the country, so that wherever the patient is coming from, we should make sure that they are facilities that can take care of them. If there's a CHIP center that they can go to, which is nearer to them, they should be able to access it and access healthcare as well. The facility should be close to them, enough to them, so they can go there when there's an emergency, or when they want to walk in, or whatever they want to do. Equitable, depending on what they do, wherever their level of, whether economic status or whatever, they should be able to have affordable care. And comprehensive health care. The comprehensive here is a bit, I find it a bit funny though, because sometimes you go to facility and whatever you need to do, you are not, or the treatment that's supposed to be given to you, you are not able to access all. But all the facilities are trying their best, be it teaching hospital, be it child, be it the faith, but everywhere they're all trying their best to make sure that we do comprehensive management for our patients. The highest quality that each facility can afford, they are doing that. And within the resources of the country. We know it's a bit difficult sometimes, depending on even what the NHIs will be paying for certain treatments, and then whether you have any private health insurance or is that the national health insurance that you are dependent on. It means that when you are going, you have to have some money on you as well. So although the resources of the country says the NHI, you are under cover of the NHIs, it doesn't cover all treatments. So sometimes you need to also pay yourself. And then respect for the patient as an individual have the right of choice. So what they can decide whatever they want to. You have to let them know that they have a choice. They can make their own decisions. And this brings to mind a lady who had diabetes that I managed some time back, a long time ago, about 10 years ago. And sometimes every now and then I remember the case and I find it so interesting. Formerly, it sounded so funny to me, but now I find it interesting. She had diabetes and her sugars were very bad. So we had discussion, we did advice, she agreed to go by all that. Then she came back and her sugars were fine, somehow fine, better than she walked in with. So I asked her to let me know what she's been doing. And she said, oh, she remembers everything I told her, but then she refused to abide by it. So I asked her, well, he said, oh, she just didn't feel like going by the decision that she made, that she was going to go according to the plan. So I thought that probably she didn't remember, or she couldn't really phantom what I had told her, what we had agreed on. She herself agreed. And she was able to verbatim tell me exactly what we said, what she agreed on, what I had discussed with her, but she said no. She just refused to abide by it because she thought it was a border, not restrictive, but a border. So she didn't want to do that. But she was somehow fine. So what can you do? It's a right, it's a choice to do whatever she wants. And then the right to protection from discrimination based on the culture, ethnicity, language, gender, religion, age, and type of illness and disability. Sometimes some of the patients come in and depending on how you see them or whatever your own informed decision you've made already about certain people, you might decide not to treat certain people in a certain manner. I'm trying very well to choose my words, to manage my words well, so that I don't say anything that might be offensive. Yeah, so you might decide that, oh, I've had an experience with this group of people before, so I wouldn't want to treat any of their kind well. But that you cannot do that. You have to treat everybody well. So Ghana Health Service, for instance, to help with disability issues, those who are hearing impaired, that's how we call it, hearing impaired. And Ghana Health Service is going through a sign language education teaching for some of the staff, and a lot of the staff rolled on, and people are now good with the sign language, so they can help those who come to facilities and are hearing impaired to at least help with the basic signs, and we are still going on. So for some reason, I was so busy at a certain point since I couldn't join. I was so sad I couldn't join. Because about some 3 or 4 years ago, I started learning it. And I got engaged in other things and I couldn't learn to complete the course. I started just a little and I couldn't complete, but now people have done it and they've really gone so far and it's really helping. And then it's also the responsibility of the patient for personal and communal health through preventive, promotive, and simple creative strategies. And this reminds me of the hand washing advert on TV, the popular one, you know, when the lady went to the washroom, came back, she was coming to turn the fufu in the bowl, and then her hands were all dirty. So the color purple was used to display what the germs would be on. And I think that's a very good thing. So that's communal. So you are supposed to also make sure that you take care of yourself and those around you. So it's not only for your own health, but for the community, for everybody around your family members and everyone. Please, you can go on. So Prince, please, you can change over. Thank you so much. And then we have a phrase on behalf of the patients. So who are those who can exercise the rights of the patients, or the responsibility of the patient is supposed to do? I mean, who are those who can exercise those rights? And we have the accredited representatives. So these are given approval, official approval to act. Those who've been commissioned or licensed, those who've been authorized, endowed with authority, so many. And I think GAND would like this one very much meet the standards of that profession. I know GAND is always on that, so they would really like this to meet the standards of that profession. And then, so unless the person is accredited, they cannot do so on behalf of the patient. These could be lawyers or whoever, any legal representative. Somebody with an authority note on behalf of the patients can also make decisions for the patients. And then we have the recognized representatives. So when it came to all this, I called the lawyers, the rep from the medical legal unit, and asked, I want to know the difference between accredited. Although I had a little idea, I wanted to make sure that I understood it very well. So from the recognized, what I was told was that it's those who have the goodwill of the patient at heart. So It could be a family member is not really interested in the patient's welfare. So if the patient is, let's say, very rich or has a property that the family member wants, they could say that, oh, just kill the patient or just have it done with patient. Oh, this people, you don't have money for that. You can't do the problem. The patient can pay, has the resources to pay for that, but someone who is not interested in the patient's welfare will not be bothered in the least to continue the management or treatment of the patient. So somebody who has the good of the patient at heart, and not someone who just wishes the patient dead. And it could also be somebody, so ask, could it be someone who is in charge of the trust fund of the patient? And I was told yes, that's also possible. And if the patient has also has an identified contact, so that if he or she is unable to make any decision, somebody who can be spoken to, it could be that it's not even a relative, it could be a relative, fine, but it could be that it's not a relative at all, but someone who has any blood relation at all. And I'm told that even if the person is married and has given clear advance directives, the married partner cannot make any decisions based on the patient's, choices that patient has to make, or they make any rightful decisions for the patient. If any advance directive has been given, then we should abide by that. And then on behalf of minors and patients, actually, we are going to go through this, and afterwards we'll have discussion. Okay, so on behalf of minors and patients, and this also takes me back to when I was really active in the management of diabetics patients, diabetics. And then sometimes we have relatives when you have the diabetes, patients come in to see us, we talk to them about hypoglycemia management. So we take them through the doses, the sugar doses, the drinks that you can take, the sugar drinks that you can take, and the drinks on the market. The different amounts and quantities and all that. And sometimes they go home and they tell their relatives that, oh, I'm told that when I have hypoglycemia, because they know the symptoms, we take them through all that, I can take sugar. And the relatives will say that no way, there's no way, when you have diabetes, you cannot take sugar. And under no circumstance will they allow the patients to take sugar, even when they are experiencing hypoglycemia, when they know very well that these signs that I'm having, I'm feeling dizzy, I feel too weak, and I need to take some sugar, the relatives will not allow them. And they'll try and hide all sugar sources from them, anything that contains sugar from them. So what we did was that we then asked you that whenever you are coming, come with a relative, someone who is very, interested in your health and your welfare, so when they come, they also listen, so they can also help you in the management of your diabetes. And sometimes some patients also hide their disease conditions from their relatives because they are afraid of what people might do when they realize that. Because we had a patient, for instance, a man, when I was at the Central Regional Hospital, we used to have a diabetes discussion group. Some of them wouldn't want, like bankers, certain workers of a certain class, wouldn't want to join the general patients for the pep talks in the morning. We don't even want to come to a clinic to be seen and known as diabetics, because we were afraid. At that time, diabetes wasn't so, although it was, something everybody knew about, they always hide them. So we had a diabetes discussion group for those is a middle income or whatever, that class. So we're coming in the evenings after close of work, and then we take them through diabetes management. And this was very detailed. We went through the pathophysiology, for them to understand, and they were really happy, they could really understand. And this man, although he knew all the whatever he had to do, he never let his wife know that he had diabetes. He was just scared. He didn't want anybody. Probably they thought that, if they know that you have diabetes or a disease that could let you die easily, then they would finish you. Whatever the reason, some of them wouldn't let their spouses know. For some, at that time, having diabetes could even lead to divorce. So people wouldn't let others know about their condition. And also, I was also informed by the medical legal rep that if it comes to issues of minors, for instance, in the case of JW, Jehovah's Witness, or any group which refuses blood transfusion, a social worker can decide the fate of the minor and then overrule so that blood transfusion could be done. So this is the information I had. So Those who act on behalf of minors and patients, social workers, for instance. Okay. And then those who are unable for whatever reasons to make informed decisions by themselves could also have other people who could also work on their behalf or in their interest. In all healthcare activities, the patient's dignity and interest must be paramount. So the dignity of the patient is so much, so how we treat them, how we talk to them, we should be very, very careful. I was so much interested in putting on my presentation in capital letters because I said, no, this is more serious than we are, that I'm thinking that I thought it would be. It seems so serious. And I remember that, oh, these are academicians. I have so many of them. If I put my all my presentation in capital letters, they are going to mark me down. So I had to try and then tone it down and put some in sentence cases and small caps, small letters. So because this is so important, you should be very, because this is a license for you to continue working or for a license to be taken away from you. Because if you are not careful, you are taking do anything to a patient and you are taken to court, you could lose your license and could be that you can't practice dietetics or whichever, or be a nutritionist, be a dietitian or whatever that you think you are doing. You wouldn't be allowed to practice that again. And we know that that's what we are all working on, with being a dietitian, being a nutritionist, being whether a clinical nutrition, whatever we are doing with your own practice, with your, working as a government worker or somebody's facility or with your own consultancy, it could also really have a negative impact on if you do anything that would a patient deems harmful to him or her. Please, you can go on to the next slide. So the question, we come back to the question, so who is really a patient? I kept as always a patient because we could all be patients one day or the other. I'm not interested in being a patient anyway. What we see in the facility is just enough for us not to want to be patients, I'm very sure. So we could have the walk-ins, those who just come in and say that, oh, I just want to know what's wrong with me, that they are sick and they are just walking, or they just want to know what to do. Sometimes people just want to even check their BPs, their blood pressure, but we know that our facilities are so choked, and the doctor-patient ratio, the dietitian-patient ratio and all that, it's not good enough for us to be taking care of those who are not sick and who just want to come and check. I just want to walk in and check my BP. The others on the stretchers who are so sick and you just walk in and think you want to check your BP. Honestly, who would want to take care of you and even because they are so busy? So that's why the Ghana Health Service came up with the idea of having the wellness centers and also the screening units. So some facilities are really on with that. They've really done so well. They have the screening centers where people can just walk in and then have their BPs checked, their blood sugars checked, check your weight and height and do whatever you want to do and have access to other information that you want to. So the Ghana, right now, I'm the Ghana Health Service Wellness Center. That's where I'm sitting now, yes. So this is our wellness center. And then here we can come and mothers can have breastfeed. You know, we had we are still the breastfeeding week, I guess this is the last week or this week. So mothers can come in and breastfeed here, you can come and do screening, can come in. There's a bed here, there are beds, so you can come and lie down if you feel tired. There's a bed here with a screen, so you can lie down and just put the screen around you and sleep if you think you are tired. Or when people come in and they are not feeling too well, we just have some of the doctors come to see them, we check their BPs and all that, and then if there's the need for medication, fine. If none, there's no need for medication, they just lie down and rest. Either that or they are sent to a regional hospital, the Greater Accra Regional Hospital, for further management. So some of them too could be emergencies, the patient, it could be emergencies, so they are also patient either from road traffickers, then it could be anything. Those are also, and then we have outpatient, those who just work and also decide that, fine, I want to take in off. Because they are sick, so they come and then they are treated as outpatient, they are treated and then managed, and then they go back home. And you have the inpatient, those admitted or detained for a while, they are also there. And we have the referrals. The referrals could be external from probably a teaching hospital or a regional hospital, a teaching hospital, a regional hospital. Sometimes when there's no bed issue going on, and then, or maybe there are certain referrals or certain tests that could be done at another facility where this facility does not have it. So it could be referral from even a health center to a hospital, or a hospital to a health center, because probably it's nearer to you. So you've been taken care of, and then your manager can be continued at a lower level. And there could also be internal, from maybe from the OPD to the ward, or from the physiotherapy to the dietitians, or vice versa, or whichever place. International, maybe a friend is calling, or from Ghana, you have to have a surgery done, so you are traveling from Ghana to another country to have that surgery done, or for maybe another, if you are coming from that country, from a foreign country, so you are coming to Ghana, and then you are given a referral, so that you could also have your management done here. So that's also possible. And then also you have relatives. And these are the ones I like so much. You know, the relatives who, when you have family meetings, you go there and they are like, oh, can you tell me what can I eat? Give me a diet plan. And they expect you to do some magic and have a diet plan for them. But they come, some of them will tell you, oh, I did my sugar, and so they said, doctor said it was high, it wasn't too good. So I want, tell me what to eat. And when you even ask them to do a little work for it, they give me a diet plan, or give me, let's say, your dietary history. They think that's all, you don't bother, you just tell me what to eat. It's all right. I love this group so much. They are so amazing. Some of them are for external, internal as well, international. Some people are coming down from other countries, says, oh, a friend told me that you are a dietitian, so I want you to see me. Can you help me with a diet plan? Can you help? And I love this group because they think that you have to, whatever they want, you should do it for them. And then we have our friends as well. They are just like the relatives. They come with or without labs, and they think you do everything for them. And then I shifted this one down, and foes. Yes, we have foes, but are we supposed to have enemies at all? So our foes. Yes. So sometimes you come, you're human as we are, sometimes you have people that you don't really like so much. But because of the duty of care, and this part I also spoke to the collegial rep. Because of duty of care, you have to make sure you take care of them. But if for any reason you think that you have somebody you cannot take care of, and assuming you are in a hospital in a deprived area, and you are the only physician there who should take care of this patient, you cannot take care of them, you have to let somebody else know that this patient has done something to me that I think is too bad, that I find it difficult to manage the patient. So I'm going to manage the patient because I'm the only one who can afford the type of care needed. But then I would want you probably to witness my management protocol or whatever that I'm doing, so that at least somebody can there to make sure that you are doing the right thing, you are doing it in line with what you are supposed to do. Because if you are not careful, and the patient one day reports that because I've had a graduate, you had a graduate with me, I've had one with you some time ago, so you didn't take good care of me. They could have a lawyer represent them and then really sue the service or anything. So you have to be careful. So duty of care, we are bound by duty of care to make sure that we afford them with the care needed. But if you think that you have any issue with that, then you have to inform someone, so another person will also at least witness your management protocol and help you. So that in case there's any questioning to be done, then at least you have a witness, somebody to help you out. So the duty of care is that you have to make sure that you take the care of the patient without any prejudice. It's so important. So everything should be documented. That's also so important. But I understand that if you don't want to take care of a patient, probably there are other specialists around or physicians around who are dietitian, another dietitian is available. So if you're a dietitian, obviously you're talking about a dietitian. So if you have a dietitian, another dietitian. So if I'm at the Rich Hospital, for instance, and RD Charity is there, a wonderful lady, she's there. When I asked her about it, she said, Auntie Ruba, you should know this. I said, please, RD Charity, you think I should know, but right now I'm asking because we are more into the clinical issues, and so please tell me what to do. I once asked her, and she laughed at me so much. But I said, Ruby, no, I said, please, you are into the clinical aspect more. So just kindly let me know, right? So I said, no, please write it down so I don't make mistakes. And she was laughing. She just couldn't believe that she needed to teach me something. So that's how it's so. understand about when it's an emergency. So if I'm at the regional Greater Accra Regional Hospital and charity is also, already charity is also there, and I think I cannot take care of a patient, I have to let our charity go ahead and take care of the patient. But if it's an emergency and I'm the only one available, and I have a grudge with the patient, I have to take care of the patient, whether I like it or not. I have to take care of the patient. So that's what I understand should be done. So you have to take care of the patient. So because if you do not do so, and it is found out that you refuse care for the patient, you could be liable to be sued. So in case of emergencies, you have to take care of the patients if you are the only one available. Okay, so please, we can go on. Please, I'm sorry for the background noise. I'm in a wellness center. We are doing a little bit of work here, so there's some small noise around. Sorry for that. So, okay, so we have this here. So the patient has, so please, the one before this, yes. So the patient has a right to quality basic care irrespective of his or geographical location. We talked about accessibility and availability, and affordability should also come, I guess, so accountability, all the A's, 5 A's should be here. And then the patient is entitled to full information on his or her condition and management and the possible risk involved. I have to read this through. Except in emergency situation when the patient is unable to make a decision and the need for treatment is urgent. So this is the right to information and then decision making as well. So they need so recently there's the Right to Information Act, which is still going on. We are all being encouraged to join when there are such meetings, Right to Information Bill and all that. So we had one recently at Ghana Health Service Headquarters last week. Yes, I think somewhere last week. It was very interesting. But I was at another meeting. I couldn't listen fully to everything because the network wasn't so good. So they have the right to their information, for them to know whatever you are doing there, how you are managing their condition, and then the possible risk involved. We have to let them know. If they don't understand it too well, for instance, you have somebody who has a little mental issue or is depressed or whatever, they have to let a relative who can understand well, somebody who is accredited or a representative who can really take care of the patient and be available, so they will know whatever decision you are making and also agree to it and probably explain to the patient that this is what is supposed to be done, and if you agree, so we'll just move on. And then decision making, so they cannot make the best decision, the patient's best interest. Okay. And then you also have to let them know of the alternative care that's available. If the person is supposed to have a surgery, and says, I don't want a surgery, or the person has to, probably we are dietitians, we are nutritionists, and the mother is refusing to let the baby take the RUTF. And the mother says that when my baby was a little, we don't take groundnut because the baby doesn't take groundnut, because when she take groundnut, she gets sick, she gets cold. So what are the alternative alternative nutrients that can be given, or food items that can be done, replaced, so that the patient can also have the full benefits of the nutrients that we want them to have. Could be if there's any other medication to be taken, they might decide to go for traditional medicine. If you are looking at the broad healthcare issues, then we also have to look at the referral policy, which is so important now. And the referral policy too was also done in 2012, and then it was printed in November 2010. And the new one, and I know a new one's also underway. They are upgrading it, reviewing it to include other issues. So it's also there. And then now we have the referral form is there, and then referral feedback form is also available. So when you send a referral, you're supposed to get a feedback. It's so important so that there'll be continual care. At least the referral hospital also know, of referral units also know what exactly you are doing, whether you followed up with what they referred you to and their treatment plan, or whether you made any changes. So if the patient should come back to them, they also know what to do. Okay, RD Prince, please, you can move to the next slide. I already, okay, thank you very much. The patient has a right to know the identity of all her caregivers and other persons who may handle him or her, including students, trainees, and ancillary workers. I think dietitians and nutrition, we are so good in doing this. Usually when we have workers around, when we have patients around and the other workers, we usually introduce ourselves and let them know, because usually we have so many interns around us. So we do introductions, and I've witnessed a lot. When we travel around doing monitoring, I see the nutritionists, when you go to ANC, they do introduce themselves to the patient, the mothers. I think it's so beautiful. I see the nutritionists doing that a lot, and I've seen dietitians also doing that a lot. It's really nice to have them, and it's just the respect given to a patient is so much, and it makes you feel that, oh, so if you're a patient and you wouldn't have any issues at all, at least you can ask them questions, they'll answer you, and they let you know what they can. And I remember this when we are in charge of the conjoined twin, and so we had to add someone onto the team because RD area mother, Greater Carolina Hospital, was going on leave, and RD area too, so was also going on leave, it's also on leave. So we added RD Matilda to help with the management of the twin. So I had to go to the ward of the twin to introduce her to the baby. So I went and introduced her. I told the baby that RD Matilda is coming to see to you to help with your management. Would you agree? He just looked at her and gave me a side eye. I said, okay, then you have agreed. So she goes to see, she was there last week and she was there this week too. So she goes there to help with this management. And RD Charity is the one in charge at the Ridge Hospital. She's doing so well. Thank you so much, RD Charity. So we do that with babies, we do introductions whenever there's going to be a change, because the mother has to also accept RD Matilda. That's okay. We have 2 dietitians going on leave, and then we are adding someone on to, so RD Matilda was also introduced to the twins, the conjoined twin mother. She also, I asked her, so do you accept that she comes? She said yes. So RD Matilda is also helping their manage. She knows Auntie Charity, she knows Chami, she knows RD Chami, RD Ariam, she knows all the team members. Yes. But she was a new person, so she had to be introduced, and she accepted. The baby also accepted, so so that's what we do. And the patient has a right to consent or decline to participate in a proposed research. Obviously, after that's why when we are doing any research, we fill consent forms. If you agree to go on with it, fine. Then you fill, you either sign or you thumbprint, so that we know that you've really accepted to do so. If we decline, that's fine by us. That's, you are not bound in any way. You can accept or decline. So that is it. And you cannot be, any service cannot be withheld from you just because you refuse to participate in a research. You are entitled to the full care and effective care available. Okay, RD Prince, please, we can go to the next slide. Thank you. The patient has a right to privacy. And when it comes to privacy issues, sometimes I find it a bit, not worrisome is too strong a word, but sometimes we have little space for consultation. So we do manage with what we have. But when it comes to, if it's not issue that has to do with undressing a patient, or the patient needing to maybe show some private parts, or shows maybe the person's, assume the person is a Muslim, our sisters and brothers dress fully, and you tell them, and you're a male taking care of them, you tell them, and then probably their attire or their dress gets lifted up a bit. You have to quickly turn away so you don't look at them, because that's them. If you have a reverend sister coming to your facility and then her veil on the head shifts a little, you have to quickly turn your head up so you don't look at it, because that's some form of privacy. So we don't think that privacy is only when somebody has to undress. No, a little showing of skin or whatever, depending on whether the person is a sister, a Catholic sister, or a reverend father, or a Muslim clerk, or you have to show that you are very much aware of the situation. Although it's not your fault that probably any part is showing, you turn away to let them know that you really value their privacy and you are careful of their rights. So that's very, very important. And then confidentiality, yes. So whenever we are doing anything that we are doing, we make sure that all the information that we have from them is really covered. We don't give it out easily. So if somebody should ask any question, whether the person, third person, or what, unless this walks in and says that this is my relative, this is a friend, this is someone that then you can release that information. If not, you can't do that. You cannot give them any information that they are just asking of. You have to be very, very careful. And all relevant information too, they need to get it so that you don't give them some information and leave some out. So far as they are asking, you give it to them and let them have all the relevant information needed. But regarding policy and regulations, so that if there are any waivers, whatever, they have to be aware of it. And procedures for complaints, yes, they have to be aware of this too. We used to have complaint boxes and suggestion boxes around, so patients can drop in their suggestions. So if they have any complaints, they can drop it in, and it really helps. So sometimes patients feel that it's the workers themselves who open the boxes. So at other places, what is done is that the top management actually lock the boxes and take the key with them, and then they take the keys away with them. And when they are ready, they just come down and open, so that they know that it's the management which is opening the box and not just anybody who can decide to take something out. And also hospital charges to also be made known to them. Mode of payments, anticipated expenditure, and should be explained prior to treatment. So they don't finish treatment before you tell them that the treatment that we did for you or gave is 500. So when the patient can barely afford 200 Ghana cedis. So that cannot be done. So you have to let them know what's the cost of the treatment and the prices of medicines that they have to purchase. You have to let them know. That's sometimes if the doctor knows that, or whoever feels that, oh, you cannot buy this drug, they give you drugs which are less expensive. And then we have the exemption facilities too. We mentioned about the aged who have some exemptions for them, and then we have the paupers as well. So when they come, they are paupers, and then they can't afford the management. Sometimes there's a way, if there are babies who have been neglected or abandoned, and the social workers come in and also make sure that they help with their management. Please, we can go on to the next slide. And the patient's rights, and then personal safety, reasonable security of property within the confines of the institution. And this I find sometimes a bit funny, because even some of the facility car parks, health facility car parks, you see disclaimers and warnings. You park your car at your own risk. So which is the reasonable security of property within the confines of the institution? Because the facility does not do that, does not put that disclaimer over there, then it means every Tom, Dick, and Harry can just get up and say that, fine, I came here, my car the window got broken, or somebody did something to my car, my tire is busted, so the hospital needs to reimburse me or pay for my car tire. So of course, they have to put those signs there. But for personal safety, at least we have to make sure that the walkways and everything is fine, so no patient will get hurt easily. Slippery areas we cannot afford to have slippery areas. So when wiping is being done, cleaning is being done, it should be done right. And then signs put there that wet floor, be careful, whatever. All these things should be put there in place for the patients. And if they cannot, the population cannot read very well, we have to make sure that they understand it in their basic language. And then second, medical opinion. Yes, this is also very important. You always have to make, because if you don't, the patient will tell you that one day come by and say that, you never told me that I could have something else done, or you never gave me this information. Opinions really do matter, because you can't have everything in your head. Somebody else has to. If you don't know, can just ask, or just send them. Even if they are sitting in front of you, you can call someone and discuss with the person. I have this patient, I have this client. I just want to know, what do you think? You can ask for the opinion. I want to discuss your condition with a colleague. Can I call? They say yes. Then you can discuss, so they also know that you're also trying your possible best to help. But if you just keep them with you, that wouldn't, because sometimes you have patient diabetes, hypertension, who's been who had a condition for, let's say, 2-3 years, and they've never seen a dietitian before. I mean, and then when they have complications before they are now coming to us or being referred to other professionals to see them, and that's not good enough. I think the second medical opinion covers all these areas. Referrals within the hospital, internal, external, whatever, covers all. So move on to the patient's responsibilities. The patient should understand. So this should understand that they are responsible for their own health and should therefore cooperate fully with healthcare providers. So it is with. They're supposed to cooperate with us. So it's not just as if because they have the right, so they can just decide to do whatever they want. We are trying to protect their rights, fine. But then they have responsibilities as well. They have to ensure that they also do the right thing. So we let them understand what they are supposed to do. They are responsible for their own health, and they should cooperate fully, and then fully with the healthcare providers. They should provide, so in doing so, they should provide full and accurate medical history for their diagnosis, treatment, counseling, and rehabilitation purposes. If they keep any information, that's not going to help. I remember a case upon where there was one CPD that GAND organized, and then we had one of the medical legal lawyers coming in. So there was this one director who came and said that he has a kidney problem, a kidney issue. But then looking at him, he realized that there were other conditions that he wasn't telling us about. So the diet sheet, I remember I was the one who managed this patient. That sheet I gave to I wrote on it everywhere and wrote that based on the patient's own assertion that he has kidney chronic failure, and put him on this low protein, doing this, and wrote everything there. And the diet sheet was full, all the corners, top, side, and bottom, I had written them. And the man realized that I wasn't joking, because I realized he wasn't telling me everything. So he came back on his the following week, was supposed to come back. The following week, he came back and he had HIV/AIDS and he had TB. So just imagine what I would have done and what would have happened to him if he had just gone on with that low protein and whatever. Because he didn't have the full diagnosis, because he needed to do other things. He was hiding his ID. So he even sitting in front of, when you mentioned the HIV or the TB, he just cringes his way. You realize that he just doesn't want to hear those words. But then he had a condition, but he just was, whether I should use the word denial, I don't know whether using the word denial would be appropriate in this sense, in this context, but he just didn't want to hear the word HIV or TB. So he was refusing treatment for that. So finally, we were able to manage him appropriately. And then requesting additional information or clarification regarding his or health or treatment, which may not have been well understood. They should ask questions. Some of the patients do not ask questions. There are some patients coming from other doctors and some other facilities. You ask them, so what were you told was your condition? Oh, I don't really know. The doctor didn't tell me. The nurse didn't tell me. And then, so you, the dietitian or whoever is going on ahead with it, you have to now go back and explain everything. Yes, we know it's our duty. We do that very well. I mean, dietitians do that very well. Nutritionists do that so well. So we have to let them also know about their condition. Please, you can go on. And then complying with prescribed treatment, reporting adverse effects, and adhering to follow-up requests. Yeah, this is so important. They have to comply. Some of them, their treatment, they just decide that, oh, I've been given an anti-cholesterol, that I'll take it for just the first month. After the first month, I won't bother taking, because they have to come for you. I won't bother. It's okay. When I feel I'm not too fine, I'll go and get some medicine from the pharmacy and take. And some of them, when they have adverse events, they won't even report it. They will just be there. They had such a case, and the diabetic had her one leg amputated because she refused to come back to report that when she was supposed to put on the insulin, and she was given the fast-acting insulin. So when she takes it, she just goes into hypo, and decided that the health workers were managing her well. And she never reported, bad sugars, she had bad gangrene, and the amputation had to be done, and the management, she finally died. And so if she had reported quickly and let us know what was going on, we could have really helped. And probably she wouldn't have died and the amputation wouldn't have been done and she wouldn't have died. Okay, so they have to, and then I think that we should also really document when they do come for follow-ups, really document so that if in any way there's supposed to be any legal, should I say, context and all that, we should be able to provide the document that we have that, oh, this patient was supposed to come and never came, so that we are also able to provide information for the medical legal people to also do their work. And then we have, if you also remember that people have the idiosyncrasies, I never seem to pronounce this word very well, idiosyncrasies, yes. And it's funny how this can really affect for the idiosyncrasies. And it's really true, and it does affect people. Sometimes I think that's all, they are just being funny and just making noises and complaining so much, but it does really happen. We have to look at the allergies and intolerance, it's also very important. We also have another DM who also has his own treatment plan, won't follow anything. He just decided that I'll take my diabetes drug, I'll take it, I won't take it this time, I feel. And then he's always complaining that he's not really doing well in bed, if I should put it that way. But then he's not money, he refuses to go by the doctor's plan, and then he has his own treatment plan. And then we also have to look at anticipated problems in following prescribed treatment or advice. Have to inform the patient if you are going to have headaches by taking this medicine, if you are going to do this, and let them know so they can also decide that, okay, I'll take back. If I have such problems, how do I deal with them? And they can also the pharmacist can also advise them when they come to us and let them know that, oh, you are going to take this meal. We want you to take more vegetables. Probably when you do that, maybe because you are going to reduce your carbohydrate intake so much, maybe you might feel as if you are so hungry, but then take more of the vegetables. Maybe drink your water at this time, drink your water, drink enough water, drink the necessary amount in a day, do your exercises. So if they understand that if you are diabetes, instead of the exercise, you should also keep sugar on you so that you don't feel, if you are feeling faint, you can take a little sugar, or, it's something that to let them know that, okay, so when I start doing anything, whether I start doing exercises or whether I start doing going through the diet plan, the weight reducing diet plan, I could feel more hungry. I could probably feel a little dizzy if I'm diabetic and all. Then they also prepare for such occasions. Then obtain all necessary information, which have a bearing on his or management and treatment, including of financial applications. I remember this very of a case of a client who was at a ICU and was on Xarelto, and then we had started giving the patient consult. That is to help it. The consult, had some clotting factors. So apparently, the patient was not supposed to be on, the Xarelto was supposed to help to prevent clotting. So when we started the consult, the Xarelto the test hadn't been done for the patient, for the doctors to know that there was clotting issues. So as soon as the test was done, we went to do the test at the scan. We quickly stopped the consult and realized, okay, the doctor said there was clotting, some clotting issues, so we quickly stopped the consult. So we have to look at all this. So if we hadn't looked at the patient's records, we would have thought that it was okay to give the consult, because the consult is so good. It has other nutrients, it has this, it does this, so it's so good. So we did that, and it really helped us a lot to prevent any adverse effects. And then acquire knowledge on preventive, promotive, and simple creative practices. So there are so many signs around. We have the regenerative health messages, we have the facility displayed messages, we have messages on TV, radios talking about how to help yourself. So the patients they're also responsible for their healthcare to seek information. And then maintaining safe and hygienic environment in order to promote good health. So they should also keep their environments clean, and their personal hygiene is also very important. And then respecting the rights of other patients or clients and health service personnel. The fact that we are patient, we are protecting right doesn't mean you can even treat health workers anyhow you want to know. They should also respect us. So sometimes, like I said, also all these patient rights, and so what's about we the health workers? And then there's also the scorecard. I'm sure the nutritionists, the family health division people will also be very much into the community scorecard, where the community rates the health workers and the facility on what they do and the services they afford. to their clients. So what later I was told that they are going to add another aspect where the health workers will also rate the community and rate the workers, because it looked as if for just the patients and the clients rating the health workers. What about the health workers also rating the community members and then the clients who come to them? And then protecting the property of the health facility. So you can't just walk in as a patient because you have rights and yet decide to be damaging the property over there, or just treating, go to the washroom, do whatever you want, just fall things around, sit on chairs, which are, if you are very heavy, sit on a chair that you know is meant for a teenager or a kid, and then break it and decide that that's all good. No, you also have to protect the property of the health facility. So please, you can go on to the next slide. I guess we're almost done. Okay, so we are done. Thank you so much for your attention. So we can have some discussion.
This is a very comprehensive. In fact, I've been thinking some of the things I think about. Then you, in your presentation, you come back to answer. But it's been very, very, very comprehensive, and I believe that many of our people will have a lot of questions. Myself, I have some questions. I'll reserve them and wait for our members to ask. Then maybe I'll wrap up with my questions. So it's now time for us to take our questions. This is Dr. Frank Report. It's a brilliant presentation, Chief. Then if we answer, then thank you very much, Auntie Ruby.
Thank you.
So now it's time for us to ask our questions, clarifications, and if you want more light to be thrown on any aspect of it too, you could go ahead and do that. If you want to speak, kindly use the emojis to raise your hand. I will call you to speak. Any questions, please? We have the attendance form posted in the chat box. Please, if you are here to fill, kindly fill it, and make sure you do you write your AHPC number correctly. Very, very important. Rosa says, thank you very much, Auntie Ruby. Thank you for the presentation.
Yeah, Prince.
Thank you.
Yes. Yeah.
I want to say a big thank you to Auntie Ruby.
Sure.
Great presentation.
Thank you.
And thank you for adding to our knowledge today. And thanks for being there for us all these years. You have done a lot for the profession. And we have come far by grace, and you guys have also really contributed. I remember all the days and times you spent at Ridge and all those things till today. So thank you very much. God richly bless you.
God bless you, Ardi.
All right. Thank you very much, Adilecha. That is great. As for Chief and her contribution, we will have to write a book on it. So Dr. Frank, Report's hand is up. RD Frank, please kindly unmute and speak.
Yes, good afternoon, colleagues, and thank you very much. It's always a pleasure to listen to you, Chief. And for me, I particularly, I've learned quite a lot. It is always never too much to continuously, hear some of these things. It's very good in terms of refreshing us with respect to what our responsibilities are to the patient. And particularly today, I'm very glad to hear that in terms of the assessing, it is not only one way. It's not just the patient assessing the professionals, and now the professionals also have the opportunity to assess the patient, because it is not always the case that it is the fault of us, the professionals, being very unprofessional. There are situations where some patients are very difficult. So I'm glad, and I can see a similarity, the way if we are all familiar with Uber or Bolt. As you assess the drivers also have the opportunity to assess you as the passenger. So it's really good to know that now, as health practitioners, we also have the opportunity to assess a patient in the community where we work. So thank you very much for the information.
Thank you so much, Adi Frank. I think that was a point that I was also happy about, because along the line, it was like we have been, we are the receiving end, the practitioners. And I was getting a bit scared that if somebody came in and was a fool and wanted to put you in trouble, he can get a lot of things against you. That there was no privacy, there were plenty of people there when you were taking care of him and all those ones. But I think I realized that all these are in the context of the facilities that are available. So we'll not say our facility, my consulting room cannot ensure privacy, so I'll not take care of patients again. So we have to improvise and try to use what we have to help our patients or clients. Thank you. All right. I think I have okay. Okay, they are rather asking of the links. All right. Okay. Any other question, please? Anybody with a question? Can you raise your hand? Dr. Atta, please. So you said something about those who have the duty of care. And I don't know whether I heard rightly that you said if a spouse wasn't allowed to make a decision for their spouses when they cannot make a decision. Did I hear you right? I don't know whether I heard it correctly.
Oh, okay. That had to do, the duty of care had to do with when somebody is a fool or an enemy, if I should use that strong word. So the duty of care, so if you have someone who comes to have a grudge with a person, probably a person as you were driving to work and a person smashed your car and then spoke badly to you. And then you get to the hospital and then the person comes to the dietherapy unit, the dietherapy department, dietetics department for you to see to the patient. What do? Because the person made you so, you were so enraged, and what you just can't imagine why somebody should do that to you. So such a person walks to you, then you are bound by duty to take care of that person. But if you are the only one around, but if not, then if you have another dietitian available, kindly let the nutrition officer, the nutritionist, or the dietitian take care of them and explain to them that because of this, that, and that, you cannot take care of the patient because you think that you might be biased in your management. So that has to do with the duty of care. And then, but if it's an emergency and no matter what the person has done, you still have to take care of the person. The person has even killed somebody, a relative. If it's an emergency and you are the only person available to take care of the patient, you are bound by duty to do so. But those is a recognized representatives. Those, assuming somebody has said that, okay, I am likely to go into shock, cardiac arrest or something. So it means that you might be sent to you are going to go through a surgery, and you've been informed of the possible risk involved. That if we do this surgery, you might lose so much blood, you might do this, you might go into cardiac arrest, you might send to ICU. And it means that you might not be able to communicate with those in charge of your management, of your treatment. So then you name someone that if for any reason I cannot talk to you, communicate to you, this person has my best interest at heart. So this person, it means you've given an advance directive so that this person can stand in and make decisions for you. So even if your spouse comes in and says that, okay, this is my husband, this is my wife, I'm come to make decision. No, they cannot do that, make that decisions in your interest because you have named someone. You have given an advance directive already. So that person, that spouse cannot make decisions for you.
Okay. I think I get it now.
Yes, please.
So if let's say the person named the spouse, then the spouse will be the accredited representative.
Yes, please.
All right, thank you. We have an exotic dietitian by name of Mavis Asamoah Pege and RD. The hand is up. Exotic, please kindly unmute and speak. RD Mavis, kindly unmute and speak.
Good evening, Auntie Ruby. I love your presentation. It was so spot on.
Oh, thank you so much, dear.
I want to.
And I love your exoticness.
Forgive me. I'll try and bring the broth down.
No,
you know,
we like it.
I just wanted to share a funny situation that happened. You just mentioned it. So I was on my way to clinic to go see my patients, and on the way there, you know, I was realizing that I was going to be late, so I was rushing a little bit. Let's say my foot was a bit heavy on the speed. So I noticed that there was another car that was following me, you know, he too, whatever. And then at some junction, he cut me off and then he proceeded ahead. And I was thinking in my head, Akwe pa. So I get to clinic and I noticed that as I'm pulling in, that he was ahead of me. So I noticed that he pulled up and he parked. So I also parked and I walked in and, you know, I recognized him. So I sat, I went into my consulting room, and the very first patient was this gentleman.
Lo and behold.
And lo and behold, right? And he's like, oh, doc. And I said, oh, dietitian maybe. He's like, oh, the way I was cutting people off trying to get here early, I hear, you know, you're very timely with your time. So I didn't want to be late. And, you know, and I jokingly said to him, that's okay. It was me that you cut off. He's like, hey, so I just bring that in to make the point that sometimes too, we are all humans. And we have to be very mindful of the fact that we can be vulnerable at any time. And just because somebody has done something to you or they've said something to you, as a professional, that's the key word. You have to remain professional. You still have to exercise and do what is right as a form of, even say, morality. You can't say, oh, this person has done this to me, so therefore I won't give them the full dietetic treatment or that I would give anybody else. We must put our emotions aside and give the best that we can, no matter what the situation is. Because the irony is that it only takes a second for us to become patients. We maybe have the upper hand now, but it only, as you said at the beginning, we somewhere along the way, maybe we might become patients. And we hope that that person who we meet will have the compassion and the understanding and the empathy to give us the best of care as well too. Thank you so much for a wonderful presentation.
Thank you so much, dear Exotic.
Thank you, Exotic, for your exotic intervention. God bless you. Yes, please, any other question? Otherwise, we will wrap up. We've done almost 1.5 hours. I believe that, you know, when experienced people speak, they don't speak much, but they give all the important points. I've learned a lot today, and I know you have to. Okay, so Adi Titidonko Prisla says, great presentation, Adi Ruby.
Thank you.
And we have to take time to celebrate your doctorate. So you have to tell us where the party will be, so we'll join. Yeah.
We'll be singing where the party day today.
All right. Okay, so it seems that we don't have any more questions, and there are no hands up as well. So I would want to say a very big thank you to you and Mr. Abet Yaunu for being online for us. We are so grateful. I know our people are well equipped, and our attitude towards our patient and our mindset would have been well shaped by this presentation. Once again, thank you, Dr. Ruby Ard.
Thank you so much. Thank you so much.
On behalf of the governing board of the Ghana Academy of Nutrition and Dietetics, I say a very big thank you to you for having time or making time to give us this all-important presentation. I know this is not the first and last we are going to have you. We have subsequent CPDs ahead this year and next year, and I know you will be available to be of help to us. Please, my dear professionals, nutrition and dietetic professionals. Our big day is coming in October. Conference of Nutrition and Dietetics, COND 2023, coming off in KNUST Kumasi in October. Please, I know that you've seen the flyers. Those of us who are here to register, let's register. Let's register and enjoy the early bird registration fees. And let's make arrangements to get to Kumasi KNUST in October, right? So we'll have special sessions for COND. God willing, next week, we'll have the opportunity to speak to you about everything about COND. Do your best to be part of that webinar. I think it will be next week, Monday and Tuesday. Also, this month is our CPD month. So next week, Wednesday, we have a CPD. Next 2 weeks, Wednesday, we have a CPD. Next 3 weeks, Wednesday, we have a CPD. So please, let's orient ourselves for that. And many more insightful CPDs are on the way. Please kindly also consult your schedule, the schedule we gave you. But let me give you a gift about the CPD we have for next week. Just a minute. Yeah, so God willing, next week, that is 16th of August. 16th August, we have the ABCs of preceptorship. So we have Professor Wright, the president of the Academy of Nutrition and Dietetic USA, will be speaking to us, the nutrition and dietetic professionals who have a lot of mentees under us. She'll be speaking to us on how we can do the right thing as preceptors. So please, let's speak to especially all the heads of units and all senior, all RDs who have people under them, and those who are aspiring to be preceptors. Please we can't miss next week. Next week is an extraordinary session as well, like today. Let's all of us be around and learn how we can be great preceptors. All right, Lynn, I saw Lynn's hand up. You can speak before we wrap up. Lynn, you can speak now. Oh, Lynn.
Hello.
Yes, you can speak.
Hello.
We can hear you.
I think my first time doing the so I don't know how I'm going to find out.
Oh, your line was breaking. Can you please restate what you said?
Yeah, this is my first time joining the program, so I don't know how my points.
This is the first time you've joined?
Yes.
Okay. So please, are you able to access the messages, the messages on your phone right now? I'll put my number there. When we close, you can call me.
Yes. So I don't know if you can give me your line to me so that I can call you then.
Yes. I'll send my line to you so you can call me.
Through which mode?
I'm sending it to you in the chat box. Can you reach the chat box?
Mention your number to me right down.
Okay, you can take the number now.
Yes.
054
Yes.
9 79 38 78.
78.
Yes. Can you mention the number?
738. Name is Dog.
All right, so we will end here. I want to thank all of you once again. God willing, we'll all meet on Monday to discuss the cont, Tuesday to discuss the cont, then Wednesday, Prof. Wright from US will join us as we talk about preceptorship. God bless all of you and see you on Monday.
Thank you for having me.
Dr. Ruby Atta, we are proud of you.
Thank you, dear.
Dr. Asante, thank you for joining. Dr. Kasim, thank you for joining. Hey, Alice. Dr. Koyo Dabra. Thank you for joining. How are you? It's been a long time.
Very long time.
Yay.
I'm doing well.
I'll call you.
Okay, okay.
Okay. Our indefatigable secretary and PRO. God bless all of you. So please, I believe all of us have filled the forms. If you haven't done it, so kindly do so. All right, so bye-bye.
How did Prince, please, the link again?
Hey, Sarah, I've sent the link. My hand is even tired. Hey, madam. Madam, I'm sending it again.
Yes, please, thank you. Aiko.
Yeah, you get an email from me this evening.
Yes, please. Thank you.
I've sent it. Have you seen it?
Yes, please. I'm going to check.
No. Okay, wait. I think it's gone to someone. Okay, I've sent it.
Yes, please. Thank you and have a good evening. Everyone have a good evening.
All right, you too. Bye-bye. In the next 1 minute, we'll hang up. So please kindly fill it.
Oh, quite better in here. Now, gonna me. I never like on food. My brother. In our field. Yes, I say, man, I don't go to la way.